Hello and welcome to third instrument class. Today we are going to discuss on endotracheal tube, suction catheter, daily mucus extractor and infant feeding tube. Let's start with the endotracheal tube. Endotracheal tube is flexible plastic tube which is inserted through mouth and sometimes even through nose into the trachea. Trachea is the windpipe to maintain the airway and ensure proper ventilation. ET tube can be cuffed ET tube like this, and then it can also be uncuffed. In detail we'll discuss in the upcoming slides. Let's start with the parts of the ET tube. It has patient end which is beveled, and there is a side opening known as Murphy's eyes. Tip is also opened, and there is a cuff in the cuffed endotracheal tube. This cuff is not there in the uncuffed endotracheal tube. After this there is a tube like this which is transparent. You can see the secretions through this, and this area is also marked in centimeters, which decides the depth of insertion of the tube. Then comes the connector. So this connector can be connected to the ventilator or the ambu bag, and this is also known as machine end. And then attached to this there is one pilot tube balloon. So here through this you can push the air, and then this one is connected to the cuff, so you can inflate the cuff by pushing air through this pilot tube. So these are the parts of endotracheal tube. The materials, it can be made of red rubber known as Indian rubber latex, which used to be used earlier, but these days this is not used. These days PVC ET tube is used, which is polyvinyl chloride, which is a flexible plastic material. Let's start with the uncuffed endotracheal tube. So this is made of PVC material which is cheap and disposable, and this can be used safely for a prolonged time. And this tube is transparent so that you can see the secretions, the secretion, color of secretion, amount of secretion, everything is visualized in this. And there is a vertical radio opaque line which is visualized in the X-ray, so you can see whether you have placed the tube in position by taking X-ray of the child after inserting the ET tube. And in the end, on the tip, it has there is a black line like this. So this black part is called vocal cord guide. So this guides you how deep you are going to go after you reach the vocal cord. An uncuffed ET tube is used usually in the neonates and children, and in children less than 1 year old. And there is a Murphy's eye. This is one additional hole, like in the same as in the cuffed endotracheal tube. Here also there is a Murphy's eye, that is a lateral opening. So advantage of this is this additional hole is going to allow ventilation if the tip is getting blocked. Sometimes tip gets blocked. So when the tip is blocked, patient can still ventilate through this Murphy's eye. Next is cuffed endotracheal tube. The parts I have already described. So this cuff is inflated via a syringe with the air. So air volume should be 4 to 8 ml of air. So this actually in this bulb, it is the measurement is written. If it is written 4 ml, then you should be introducing 4 ml of air to inflate this cuff. If it is written 6, you will inflate 6 ml. So this way the range is 4 to 8 ml of air you can introduce through this to inflate this cuff. So cuff should be 2 to 2 cm below the vocal cord. Cuff pressure should be less than 30 cm of water to prevent the tracheal ischemia. So best will be to measure the pressure regularly every 8 to 12 hourly by using a cuff manometer, which is going to give you the accurate measurement. So that is the best way to check the cuff pressure. It should not go above, it should always remain below 30 cm to prevent the tracheal ischemia. and this type of ET tube is a low pressure high volume type of ET tube, so it is causing less injury to the trachea, and the cuffed ET tube is usually used in more than 1 year old children. The advantage of cuffed endotracheal tube is it prevents aspiration because it is tightly closing the respiratory passage, and then it does not get displaced easily. And disadvantage is if the pressure is too high, then it will create pressure necrosis in the surrounding soft structures. Now come to route of insertion. Endotracheal tube can be inserted through the nose like this. So here the patient is beveled at the tube is beveled at 90 degrees, and it can be introduced orally. So more commonly oral intubation is done. So here the tube is beveled to the patient at 45 degree angle. Next, come to the size of the ET tube. What size you should be using? When we talk about the size, we are meaning the internal diameter. So in every tube it is written ID dash this millimeter. So the available millimeter is starting from 2 millimeter till 18 millimeter is available. So always check the ID measurement, and then that will be the size of the ET tube requiring for the child. So weight, if the baby's weight is less than 1 kg and gestation is less than 28 weeks, you should be using 2.5 millimeter size tube. If the baby is 1 to 2 kg and gestation 28 to 34 weeks of gestation, then you have to use 3 millimeter size tube. If the baby is more than 2 kg to 3 kg, more than 34 to 38 weeks gestation, then you should be using 3.5 millimeter tube. If the baby is more than 3 kg and more than 38 weeks gestation, then use 3.5 to 4 millimeter tube. And above that, 1 month to 12 month till 1 year of age, the tube size should be 4 millimeter. Then beyond 1 year, the formula method is used. So 1 to 6 year, if you are using uncuffed tube, ET tube, then the formula will be age in years divide by 4 plus 4. If you are using cuffed ET tube, then age in years divide by 4 plus 3.5 is the formula. And roughly in emergency situation, if you forget the formulas, always remember the ET tube size, that means that is the internal diameter, should be of the little finger of the patient. So just take the little finger of the patient and measure the tube, and then that will be the size for that baby or the child. If you forget the formula, you can do that in emergency situations. And now come to depth of insertion, how far you should be introducing. We said we can follow the cuff to 2 to 2.5 centimeter above the cuff, or we can use the vocal cord guide, but many times under the throat it is so difficult to visualize. So those scenarios you can use the formulas. So in case of newborn, the technique is weight in kg plus 6. So if the baby's weight is 1 kg plus 6 means the depth of insertion should be 7. So in the tube I told you there is marking in centimeter, so you have to fix the tube at 7 centimeter at the angle of the mouth. If the weight is 2 kg, then plus 6, that means 8 centimeter, and then 3 kg 9 centimeter, and so on for the newborns. Beyond the neonatal age, the depth of insertion is decided by using formulas. So you can, in infant and children, the depth in centimeter will be age in years divided by 2 plus 12 centimeter, or you can do 3 into tube size, that is the internal diameter in millimeter. Suppose the tube size is 3, then 3 into 3 3s are 9, so you are going to fix at 9 centimeter, or the depth of insertion will be 9 centimeter in that case. And always remember, tip of the tube should be 4 to 5 centimeter above the carina. Carina is a point where the trachea is divided into 2 principal bronchus. So if you keep the tube 4 to 5 centimeter above, then the air is equally passed in both the lungs. So in emergency situation, if you don't remember the formulas, roughly the length or the depth of insertion can be decided by taking the distance from the ear lobule till the tip of the nose. So from the tip of the nose till ear lobule, you measure the tube. So in that length, you just add +1 centimeter. So that will be the length of the insertion of the tube for that child. And in case of nasal ET tube, always you take the length of oral tube, and in that you can add on 3 centimeter. Suppose here you had done 3 into 3, so that was 9 centimeter. So if you insert the tube through the nostrils, then the length for this case will be 9 centimeter plus 3. So 9 plus 3 will be 12 centimeter. So that way you can decide if you are using the nasal route. Indications of using the ET tube in the newborn. Number 1, when bag and mask ventilation is ineffective. Number 2, when intermittent positive pressure ventilation is required for a prolonged period. 3, direct suctioning of trachea is required in case of meconium aspiration. Number 4, during the resuscitation of the newborn, when the bag and mask ventilation is ineffective, or when chest compression is required, or if you need to give medication through the ET tube, that medication like adrenaline, so then also you have to intubate. Number 5, RDS, that is the hyaline membrane disease, when you have to give surfactant, or when you have to use CPAP. CPAP is the continuous positive airway pressure. When this is becoming ineffective, then you need to intubate to ventilate the child. Number 6, congenital anomalies affecting airway like diaphragmatic hernia, bilateral choanal atresia. Now come to indications in case of infants and children, that is beyond neonatal age. To maintain the airway patency, you have to intubate. And those conditions where you require to maintain the airway patency is in unconscious children, whenever there is head injury, whenever there is status epilepticus, poisoning, patient is unconscious during poisoning, and conditions where there is respiratory failure leading to hypoxemia, hypercapnia impending, exhaustion from the respiratory distress, in conditions like bronchiolitis, asthma, then you have to intubate. And in conditions where there is shock, cardiac arrest, to secure the airway and then to maintain the mechanical ventilation, you have to intubate. Others are muscle weakness conditions like Guillain-Barré syndrome, myasthenia gravis, where all the muscles of the body including the respiratory muscles are weak. So to maintain the ventilation, we intubate. Another is airway obstruction if it is very severe, like in epiglottitis, croup, status asthmaticus. These conditions actually it is contraindicated, but if it is very severe, very carefully you can do the intubation in presence of anesthetics doctors. Then burn, trauma, so in this condition you have to be very careful. Now come to contraindications. Number 1, increase friability of the local area if there is laryngeal edema, and in the oral, if there is a oral mass or fracture mandible, if there is a neck injury, and if there is an inadequate mouth opening, patient cannot open the mouth like in bone effusion conditions. Then for the nasal intubation, if there is a basal skull fracture, if there is CSF rhinorrhea, epistaxis, nasal polyp, foreign body in the nose, abscess or nasal surgery has been done, then you cannot do the nasal intubation. Now come to complications. Immediate complications can be trauma to the lips, gums, pharynx, larynx or dental injuries. There might be bradycardia, hypoxia from prolonged attempts if you are trying to attempt again and again. And then number 3, esophageal intubation leads to hypoxia. And then ischemia, edema, necrosis of the local site can occur. There might be aspiration due to inadequate inflated coughs. And then sometimes you do bronchial intubation, or the tube is going towards the right side of the lung more. So because it goes towards the right side more because the bronchus on the right side is short, wider, and then more vertical. So there is chances you are doing the bronchial. This condition is known as bronchial intubation. So if you do that, then left side of the lung is getting less oxygen, and this is less ventilated or not ventilated, which will lead to atelectasis or the collapse of the alveoli, so leading to collapse of the left lung. Then next there can be tracheal tube obstruction by kinking. There can be reflex laryngospasm or bronchospasm, especially in cases of epiglottitis and then croup, and even sometimes in the severe asthma. Then there can be pneumothorax, barotraumas like pneumothorax, pneumomediastinum, and then infections, ventilator associated infections. The early complications occurs in hours 2 days later. So the early complications are: number 1, tube obstruction with secretions and kinking. Number 2, sore throat, hoarseness of voice, stridor from mucosal injury can occur. Number 3, laryngeal edema, laryngeal nerve palsy can occur. Number 4, infection like pneumonia or VAP, that is the ventilator associated pneumonia, and tracheitis can occur. Number 5, barotrauma. Number 6, lung atelectasis, that is the collapse of the lung. Number 7, pressure injury in the lips and oral mucosa can occur. The late complications occurs due to prolonged intubation. Those can be: number 1, subglottic stenosis, tracheal stenosis, tracheomalacia or laryngomalacia can occur. So these are softening of the trachea or larynx. Number 3, vocal cord granuloma, vocal cord paralysis can occur. Laryngotracheal web can form, and then chronic lung disease can occur. Now come to the second instrument of today's class, that is DLE mucus extractor. It looks like this. So the parts, it has patient end. So this one is the patient end, which is going to the nose or mouth of the patient. Then comes tubing towards the mucus trap. So this patient end is going, this tubing is going to the mucus trap. This green, the cylinder like thing with the green top and bottom, this is a mucus trap. This mucus trap is transparent, so you can visualize the secretions. There are markings, so you can even know the amount of secretion which is collected over here. And you can see the color of the secretion also. And after that, there is a tubing coming out from the mucus trap, and then it is ending in a funnel shaped structure. So this is a funnel connector. So in this connector you can connect the suction device, or you can even suction with your mouth. So this is a newer design, new form of the DLE mucus suction. The advantage of this mucus extractor is it is portable, it is cheap, it is very easy to handle, no electricity is required, and then suction force you usually do with the mouth, so suction force is less. That means the mucosal injury will be less, and it can be used by any people, the health workers, the new doctors, sisters, anyone can use. Even the patient attendants, if you train them, they can use this because the force of suction is less, so there is less chance of complications like injuries. So anyone can handle this. So this is the advantage of the DLE mucus extractor. Use is suction during the resuscitation of the newborn you can do, or any secretions in the mouth or even meconium in the mouth can be sucked out through this extractor. Another instrument is suction catheter. So let's see the parts first. It has two ends, one is patient end, another is machine end. So this one is the patient end, where there are two openings, one at the tip, so tip is opened, and then one at the lateral side. So there are two openings, one in the tip, one laterally. And then this is the tube, and this end is known as machine end, which has a funnel shape. It has a funnel connector. So this can be connected in the suction device. There are different colors. So these colors are indicating the size. Size is measured in French gauge, that is indicating the external circumference of this tubing. So with different colors it indicates different sizes. So 6, 8, 10, French gauze 12, 14, you get till 20 French gauze. These are the different sizes. So in case of children till 12 we use. The use of suction catheter. Number 1, suction of secretion from mouth, nose, pharynx, nasopharynx, larynx and trachea. Number 2, you can do the diagnosis of choanal atresia. So bilateral choanal atresia, soon after birth you try to insert this tube, it will not go in. And number 3, oxygen administration through the nose, as you can use as a nasal prong when nasal prongs are not available. You can artificially make this as a nasal prong and then use. And contraindication is any friability is present in the local area, which occurs usually due to acid or alkali poisoning. So if the area is friable, if there is a trauma in the local area, then you cannot use this. Okay, next instrument is infant feeding tube, which is very similar to the suction catheter. So you have to know the difference between these two, because this tube also has two ends, that one also has two ends. This proximal end is containing cap. So this cap is closed in a feeding tube. So this cap is not present in the suction tube catheter. And there is a distal end known as the patient end, which goes to the stomach of the patient through the mouth or nose. You can insert this through mouth or nose, and this end goes to the stomach of the patient. The tip here is blunt but has 3 side openings, 1, 2 and 3. So there are 3 side openings, but the tip is blunt. And then in case of suction catheter, tip was open and there was only one lateral opening. So here the tip is blunt and there are 3 lateral openings, and there are markings present which help you to decide the depth of insertion, how deep to insert. So to decide that, it will help you, and there is a markings in centimeter, and there is a radio opaque line. So this blue line you see throughout, vertical line, this blue line is a radio opaque line. So this is going to help you to visualize in X-ray how deep this tube has gone. So many times it is required, and these markings are not present in the suction catheter. Procedure to insert this infant feeding tube. In case of newborn and infants, you measure the length from alanasi of the nose to the tragus of the ear, then you go till xiphisternum, then insert either through mouth or nose till that length. So you decide the length by measuring like this, from nose till the tragus and from tragus till the xiphisternum. Then you have to check whether you have placed the tube in the correct position or not. So for that, with the syringe you can just aspirate, suction out. If you pull the syringe, then the gastric content will come out in the syringe. Another way is you inject 50 ml of air in the syringe and then push that, and then listen with the stethoscope over the epigastrium. Put the stethoscope over the epigastrium, pull 50 cc of air in the syringe, and then just push. When you push through the stethoscope, when you listen to the epigastrium, that is the area where the stomach lies, then you hear the gurgling sound or the harsh sound of this air. Like suction catheter, this infant feeding tube also comes in different measurements, and which is indicated by different color of these ends, this proximal end. So 6 French gauze, 8 French gauze, 10 French gauze. So this size, different sizes are used in case of children. Now uses is divided into therapeutic use and diagnostic use. Therapeutic use of infant feeding tube are: number 1, for feeding purposes. So you feed with the tube in the preterm infants. If the preterm is less than 1800 grams, then these babies cannot suck. So you feed these babies with this infant feeding tube. If the baby has a cleft palate, baby is very sick, is unable to suck, then also you have to use the infant feeding tube. In case of severe protein energy malnutrition, initially to give the exact measurement of calorie and protein, you have to feed these children with the feeding tube. An unconscious child also you feed with the infant feeding tube. So these are the conditions where you feed with the feeding purpose. So feeding purpose is first therapeutic use of infant feeding tube. Number 2, therapeutic use is administration of ORS, oral rehydration, salt solution in case of severe dehydration, and then sometimes you can give drugs through the infant feeding tube when the child is not taking orally. Then gastric lavage you can do in case of poisoning cases. When you are doing the lavage with the charcoal, you have to use this feeding tube. Another is decompression of the stomach. When there is a severe abdominal distension, then decompression of the stomach is done by using infant feeding tube, where you open the cap and keep it open and let the air come out. In that case, you don't use the syringe. Diagnostic uses: number 1, diagnosis of corneal atresia soon after birth. Number 2, tracheoesophageal fistula. So in tracheoesophageal fistula, you try to insert the tube. It will not go to the stomach, but the tube will remain coiled in the blunt esophagus. That is visualized in the X-ray, and that is the way you diagnose. Another diagnosis you can do is anal atresia. So through the anus, if you try to insert this feeding tube, it will not go in. So you can diagnose anal atresia that way. And in small children, we do gastric aspirate to isolate the acid-fast bacilli to diagnose tuberculosis in case of children. Poisoning analysis can be done by doing the gastric aspirate, and in case of neonates, sometimes to diagnose neonatal sepsis, we take the gastric aspirate and see the neutrophil count. If it is more than 5 per cubic millimeter, then it is significant, it indicates neonatal sepsis. And in upper GI bleed also, if you put the nasal NG tube and then keep the cap open, if there is a upper GI bleed, then bleeding blood will come out through the tube as a free flow blood will come out. Other uses of feeding tube can be when umbilical catheter is not there, then you can use the infant feeding tube as a umbilical catheter to give the fluids, drugs, and even exchange transfusion you can do with this catheter. And in a small children, instead of Foley's catheter, the infants, newborns and infants, instead of Foley's catheter, we use the infant feeding tube as urinary catheter to drain the urine. When you do venesection, when vein is not available, when you do venesection, you use this tube. It can be used as suction catheter when suction catheter is not available. It can be used as a tourniquet while drawing the bloods, and sometimes even as a oxygen catheter when the oxygen catheter is not available. Okay, thank you. Next class we'll continue with the instrument class, the remaining of the instruments like the needles and tongue depressor. So all these things we'll discuss. Thank you. Hope this class was useful for you all.